Hi, welcome to lecture 4. We're going to talk about assessment and diagnosis. So first of all, the difference between assessment and diagnosis is that assessment is more geared towards understanding the individual and the problems that they're presenting with, or the strengths and talents that they're presenting with. Whereas diagnosis is about getting information about an individual that allows you to fit them into a diagnostic classification. So in an assessment, we're looking to identify and measure clinical symptoms in the context of psychopathology, taking into consideration the biological, psychological, and environmental factors that might affect that individual's psychopathology and their behavior and symptoms. Whereas a diagnosis is more about, once we have the data that we get from the assessment, trying to make sense of that data and figure out what prototypical symptom description, i.e. disorder, it best fits into. So the online part of this lecture is going to focus on assessment. And assessment really has 4 main goals. The first is understanding the individual. So getting a sense of their personality, their personal goals, their values, and the social context that they're living in, as well as trying to understand how they're functioning right now, how impaired they are, what their roles are in life, and how they may or may not be dysfunctional in those roles. We also want to understand the symptoms. So this means getting a sense of the 4 Ds, especially deviance, danger, distress, dysfunction as well. Understanding when the symptoms started, how they've changed over time, what the person's functioning was like before, and what factors in the person's life might be associated with the onset of symptoms. So again, we're applying that integrated model where we're trying to understand any biological factors, any psychological factors that relate to belief systems, learning history, personality, and any environmental factors that relate to learning experiences, parenting, culture, the environment. Assessment is an information gathering process, and we use that information once we have a sense of who the individual is and what their symptoms are. We use that information to plan treatment, and we use it to evaluate outcomes. So in order for us to know that our treatments are working, we have to know what symptoms and level of functioning someone is coming in with. And we have to show that through our treatment, we actually change those symptoms and improve their functioning. Assessment is the source of the data that we use to make sure that we are helping our patients, in addition to guiding the treatments that we use to help them. So assessments differ in how comprehensive and rigorous they are. And part of that is about access to care. There are some ingredients that every assessment should have, and they don't always, which is a problem. But there are also some presenting concerns and differential diagnoses that require more testing than others. So assessments can include sort of 2 broad components. The first is a clinical interview, and the second is psychological testing or neuropsychological testing. An interview includes multiple different parts, but really the goal of a clinical interview is to understand clinical symptoms. So we want to understand emotional experiences, symptoms related to psychosis, mania, mood alterations, anxiety, depression, behaviors. Psychological testing is more often used to assess intellectual functioning or educational attainment, or it can be used to compare someone's clinical symptomatology, not just to their own personal baseline or where they hope to be, but to the actual population. So really one of the key differences between clinical interviewing and neuropsychological testing is that the end result of neuropsychological testing is a numerical score that you can actually compare to the population that the individual patient is coming from. So you can say relative to other people, this person's age and from the same country as them, they are functioning at a 50% lower level or a 25% higher level on this domain. So first we're going to go through the different components of a clinical interview, and then we'll talk a little bit about the ingredients of neuropsychological testing. So one of the first things that happens when a patient is being assessed and interviewed is we check their mental status. This is really just a very rough test of their cognitive functioning and whether they're in an altered state of mind. There are symptoms of psychopathology that can affect mental status, usually by affecting someone's orientation to time, person, place, or their decision-making capabilities, their ability to behave appropriately, use their prefrontal cortex to guide their behavior. But it also is sometimes used to sort of pick up on and identify neurological problems like dementia, strokes, or traumatic brain injuries. So orientation just is literally just, does somebody know who they are, where they are in time, why they're here having this assessment. Registration has to do with how aware they are or how able they are to notice things in their environment. So are they capable of visually registering the things around them? Also, are they capable of registering what you're saying to them? Are they hearing, processing, and understanding your speech? And the way that we test that is we give them 3 words and ask them to repeat those words back to us right away. And then after a brief pause where we talk about something else, to see not only are they hearing and paying attention, but also are they able to remember over a short span of time. If they're not able to understand, register, if they don't know why they're there and who they are, some aspects of the psychological assessment would have to change. And if we're assessing them for something psychological as opposed to neurological, we might have to switch gears and realize that if someone's not oriented to time and space or not capable of registering speech, then this might not be a good time to assess their symptoms of anxiety or depression. We might need to understand what's happening physically, well, on a grosser anatomical level, physically in their brain. The mini mental status exam is often, it can be administered by a range of medical professionals. It's often used in doctors' offices and primary care, as well as by psychologists doing standardized clinical assessments. Probably the most important part of a diagnostic interview, so a clinical interview that's designed to figure out what type of psychopathology a person is experiencing and how best to help them, is the semi-structured interview. So this is a relatively standardized tool that basically starts with the question, what are we trying to learn about this person, through asking them questions. And then the semi-structured interview actually includes a list of questions that ensure that we ask all the questions that we need to ask to answer our initial question, and to make sure that all patients get asked all of the same questions. It helps to reduce bias coming from clinicians in making diagnoses. Semi-structured interviews are semi-structured because they're really more like guidelines or checklists. When a clinician is doing a semi-structured interview, they're not reading verbatim off of a page. They're more just using it to guide their questioning and make sure they're not missing anything. The structure is loose, so it allows for skipping around. You can kind of follow the patient's lead to some extent, and then at the end of the interview, you can use the semi-structured interview to make sure that everything was asked, and anything that wasn't asked, you can get back to. It can be better for building rapport with someone, for helping them to trust you and feel comfortable with you when you're interacting with them like a human and not just reading questions off a piece of paper. So this is an example from the structured clinical interview for DSM-5 diagnoses of one use of structured clinical interviews, which is just to get someone's basic history, their demographics, their educational history, their work history. This part of the semi-structured interview is getting at how were they functioning maybe before the symptoms started, and how impaired is their functioning in their different roles now. These are more questions from the same interview, the semi-structured clinical interview for DSM-5, which is abbreviated the SCID. This is just a little snapshot of some of the questions that we ask to assess the criteria for mood disorders. Again, these questions can be read verbatim, and sometimes they are in research studies where less trained people are administering the interview. But in most clinical settings, when semi-structured interviews are used, it's more of a guideline. So when I'm giving one of these, I go through the questions and look at them to make sure that I'm remembering to ask about each criterion for depression, but I wouldn't necessarily read these items verbatim. Based on the administrator's sort of interpretation of the patient's open-ended response to the questions, we would use this scoring system to indicate whether the symptom that we're asking about is not present, whether it's present but not necessarily at a degree that we would consider clinically significant. So maybe it's not sufficiently contributing to enough of the 5 Ds that we would consider it a clinically significant problem. So it's subclinical, subthreshold, or whether it's present to a significant degree and causing distress or dysfunction. This is just another example of how semi-structured interviews, they don't always provide as much structure as the SCID. This is an example of a checklist version of the Children's Yale-Brown Obsessive Compulsive Scale, which is used to assess and diagnose the severity of OCD. This is just a checklist that an administrator can go through and ask the patient about the different types of obsessions they might have. So just an example of a semi-structured interview that's less detailed, I guess, and less designed or less capable of just being kind of read verbatim to a patient. Another part of a clinical diagnostic interview is often having the patient, or sometimes their family members, or in the case of kids, sometimes like their teachers, answer questionnaires. So these questions can assess whether or not a symptom is present. They can assess how severe or how intense the symptom is, and they can assess how much distress or how much dysfunction a given symptom is causing. When we talk about symptom disorders, I'm going to have you guys like looking at some of the self-report questionnaires we use to diagnose them, to just help you get a better sense of what the clinical criteria are. This is an example of the Beck Depression Inventory, which is used to assess for and screen for depression. This type of response scale is a little unusual in that each response to an item kind of has its own separate wording. So for this symptom, which has to do with a symptom called anhedonia, losing interest in things that you used to enjoy, when the symptom's not present, a person would circle, I haven't lost interest in other people or activities. And then there's 3 levels of increasing severity of that symptom. So what the BDI is measuring is whether or not a symptom is present, and if it's present, how intense and severe it is. Self-report questionnaires often have clinical ranges or clinical norms. So in the case of the BDI, there have been lots of studies done where this questionnaire has been given to people who have been diagnosed with depression, who we kind of have identified as being depressed. And then their scores on this measure are compared to the scores of sometimes samples of people who we know not to be depressed, or sometimes just general population samples. So for example, on the Beck Depression Inventory, the threshold for considering someone's depression clinically significant at a mild level is 11. But then there's increasing thresholds for moderate, severe, and extreme depression. And the BDI has 21 items. So the total possible score is 63. So these are just examples of other types of response formats. These are 2 self-report questionnaires that we use to diagnose eating disorders. On the eating disorder examination questionnaire, this is an example of a frequency scale format. So the questions refer to specific disordered eating behaviors, and the response format, it lets participants or patients indicate how many days in a typical week they engage in those behaviors or in the past week. This is the 9-item ARFID screen. It's used to diagnose the presence of avoidant restrictive food intake disorder. Well, actually not to diagnose ARFID. It's more used to assess the severity of ARFID. And that's because it's not necessarily asking about the frequency of these behaviors or whether they are causing dysfunction, distress, or any kind of impairment. It's more just used to assess how intense the behaviors are. So if someone is a picky eater, we want to know, are you a really, really picky eater? Are you strongly agreeing with that statement? Or are you more just sort of mildly, slightly agreeing with that statement? Ultimately, as we develop questionnaires and refine them and give them to more and more people, we might be able to identify clinical significance thresholds on measures like the 9-item ARFID screen. But not every self-report questionnaire has clinical significance thresholds. So when they don't, or even when they do, they can just be used within one individual to assess changes in their symptom severity. And we often use them throughout treatment to make sure that our patients are responding to treatment and that their actual symptoms, behaviors, emotions, thoughts, and feelings are changing in the direction that we want to see them change in. This is known as measurement-based care. Consistently throughout treatment, we're having patients quantify their symptom severity, their distress, impairment, and dysfunction. And if we don't see those numbers dropping, it gives us an indication that our treatment isn't working and we need to increase the intensity of treatment or try a different treatment approach or consider a different diagnosis. Okay, so at this stage, I want to just introduce a couple important concepts in assessment, and this applies to diagnostic interviews, it applies to self-report questionnaires, and it applies to neuropsychological testing. So two important considerations in deciding whether an interview instrument or a self-report instrument is useful are reliability and validity. And just really broadly, reliability asks the question, does this interview, measure, or test give the same answer in the same individual every time it's given? So with an interview, we might ask, can two different interviewers who give the same patient a semi-structured interview arrive at the same diagnosis and identify the same level of disorder severity? With a self-report questionnaire, we might ask, do multiple reporters on symptoms? So for a child with ADHD, for example, we might say, does the child's English teacher and their science teacher both agree that this child has ADHD symptoms, and are their scores on this questionnaire roughly the same? We might also ask, even with the same interviewer, but over repeated assessment intervals, does the same patient get the same diagnosis or receive the same score on a self-report questionnaire? If someone's not being treated and they have a disorder or symptom that we don't expect to go away on its own, an indicator of a measure's reliability is whether their score doesn't change. Another type of reliability is sensitivity to change in treatment. So if someone is being treated for a specific symptom or disorder, we actually expect to see their scores go down, and we want our measures to be able to capture that change and actually correspond to decreasing severity in the same individual. Another consideration in measurement has to do with validity, which is this interview or is this questionnaire actually measuring what we think it's measuring, what it's designed to measure? Broadly, there's kind of two types of validity that we care about. One is predictive, so do scores on this measure actually relate to real world outcomes? For example, we're going to talk about IQ testing, intellectual functioning testing. The point of those tests is that they should correspond to how well an individual performs at school or at work. If they don't, then they're not valid. There's no point in giving them. Concurrent validity has to do with how well does this measure compare to other measures of the same construct. If we're developing a new measure of a disorder, we always have to compare it against an existing measure of the disorder that we have evidence is reliable and valid to show that our new measure performs as well as other measures in capturing the construct, which in this case would be symptoms of a disorder. These figures, I don't know how helpful they are in understanding these concepts. I find the second one kind of confusing. But basically, if we're throwing darts at a dartboard, a reliable and valid dart thrower hits the target every time, that's validity, and every time is reliability. So hitting the target is validity, consistently hitting the target is reliability, always being able to get the dart in the same place. A measure that's reliable but not valid, someone might get the same score every time, but their score doesn't have anything to do with what's actually happening in their life. It doesn't capture what it's supposed to capture. A measure that's valid but not reliable might capture what it's supposed to capture sometimes, but that finding can't be repeated consistently with multiple administrations. So as you can see here, like one dart got in the middle, there's other darts that are close to the middle, but the darts are not close to each other. So different administrations or different interviewers were not able to get the same answer with this measure. And a measure that's neither reliable nor valid, there's fewer darts near the middle, and the darts are also not close to each other. Okay, the last important concept in assessment is standardization, which is this measure being administered in the same way and under the same conditions to everyone who's taking it? If there's any influences from the environment that might influence someone's responding to the questionnaire or might influence their performance on a test, like being distracted, being tired, being in a really hot or really cold room, being given the administration in a non-standard way, so having an evaluator asking questions that aren't on a standardized battery, or having them ask the questions using different language than is written in the standardized testing manual. So semi-structured interviews, their assessment is less standardized. The standardization comes from the fact that interviewers are supposed to ask about all the same behaviors, but they don't have to ask in the same order. They don't have to ask using the exact same language. And the administration isn't as sensitive to the context it's being done in. Standardization is a really important concept in psychological testing, which we're about to get into. And it's an important concept in measurement too. So in self-report questionnaires, when we're doing research on self-report questionnaires, we don't want people to be distracted when they're taking them. We want to make sure that everyone is at kind of the same level of reading comprehension. So administration would be non-standard if someone isn't able to understand every word in the questionnaire. But standardization is most important when it comes to norm referenced tests that compare one person's score to the general population or to a large sample of other scores. For that comparison to be valid, the conditions under which those scores were achieved has to be the same for everyone. So psychological testing, again, is where standardization and norm referenced scores really come into play. Psychological tests like the Wechsler Intelligence Scale for Children, the WISC, are standardized and they're normed in the general population, which means that an individual's score on the test means something in relation to everyone else's score. An IQ score of 100 means that the person's intellectual functioning is average compared to the population. 50% of the population scores lower than them and 50% scores higher. So because standardization is so important, because we're directly comparing people's scores to other people's scores, administration has to be a lot more structured and rigid. So whereas on the SCID, an administrator can choose to read the questions verbatim or they can ask them in their own way, on a standardized test like the WISC, you actually have to read every item verbatim from the book. There's other standardization too, like the distance apart that you sit from the patient is standardized, the way that you sit across from them is standardized, the order in which you perform the testing is standardized. So largely because of this, because standardization is so important because you have to do it the same way every time and with every patient, psychological testing tends to require more training and experience. And although people without doctorates can actually perform the testing, they're only meant to be interpreted by doctoral level practitioners. So people with a PhD, a psychology doctorate, or an MD and psychiatric training. So someone who's a psychiatrist. Psychological testing like this, norm-referenced standardized psychological testing, is most often used when the differential diagnosis, so when one of the possible types of psychopathology that someone is presenting with includes something that influences their neurocognitive performance, their intellectual functioning. So that could be something like an intellectual disability, which means lower intellectual functioning across domains, a specific developmental difference, which might mean something like average intellectual functioning, but very below average social cognition, which you would see in autism, or it could mean a very uneven profile of intellectual capabilities with average or above average skills in one domain, but very below average skills in another. Or it can be used when the differential diagnosis includes a neurological problem, like stroke or dementia. So typically when someone is being evaluated for psychotherapy, when someone is coming in with most of the disorders that we're going to talk about in this class, psychological testing wouldn't necessarily be part of the assessment because we don't need as fine-grained, detailed, and accurate information about their intellectual functioning to understand that they have symptoms of depression and to help them work with their depression. Doesn't mean that it's not important to understand the level that they're functioning at, because if you're working with someone who has an intellectual disability and also has depression, you would need to tailor your language, your rate of speaking, the metaphors you use to that person's ability to understand. But you don't need to know their exact IQ score to be able to do that. So one of the most frequently performed types of standardized psychological testing is IQ testing, intelligence quotient. This concept was originally developed as a way of assessing the performance of school children and identifying children who needed extra academic support, which sounds like a good thing, but it has in the past been used and applied in really racist, unfair, unequal ways. So when IQ testing was first developed, these tests were developed in samples of middle and upper class white kids in France. But then the test that was developed and normed on this one very specific group of the French population was then used to assess and judge the rest of the population. So in this case, it was used in kids who had a lot of educational opportunities. They had better childhood nutrition. They were more likely to still be in school as teenagers. But then the test was used on kids that had fewer of those opportunities, but their scores were still compared to the scores of kids who had more opportunities. So that's an example of how IQ testing has been used in biased and unfair ways. There, since then, has been a lot more efforts to make the tests fair. So today, IQ tests are normed in samples that are designed to be very diverse and representative. And as a result, performance on IQ testing is supposed to be independent of how much education someone has been able to get. But some tests are better at picking up intellectual functioning independently of education than others. So for example, one way that working memory, so the ability to hold concepts in your short-term memory for brief periods of time, but recall them accurately. One way that we test that is using arithmetic. So we have people solve simple math problems in their head. If someone hasn't had as much access to formal schooling, their ability to do those math problems might be lower for reasons that have nothing to do with their working memory. Similarly, one of the ways that we assess someone's verbal functioning, their ability to process complex ideas verbally using language, is we ask them vocabulary questions. This part of the Verbal Comprehension Index, the VCI, is way more sensitive to how educated someone is than the similarities subtest, where we ask people basically to think about ways in which two concepts are similar. So for example, how is music like the tides is one question. And you don't necessarily need to have a lot of formal education to be able to reason about that question and come up with an answer. So the similarities subscale of the VCI is less sensitive to educational attainment than the vocabulary subscale of the VCI or the arithmetic subscale of the WMI, the Working Memory Index. So intellectual testing, IQ testing, is used to diagnose intellectual disabilities, which is across the board lower intellectual performance than would be expected for your age. Also used to assess for learning disabilities, which we'll talk more about on the next slide, and dementia. So in the case of dementia, what we would expect to see is someone's intellectual functioning declining more than you would expect for their age. The IQ test is normed against age range. So the raw score on the IQ test of a 25-year-old is expected to be higher than the raw score of a 75-year-old. So we're comparing 75-year-olds to other 75-year-olds, but also to their own previous performance using percentiles. So your score on an IQ test actually is a measure of how you perform compared to people within 10 years of your age. To use an IQ test to provide diagnostic information for dementia, we need to know what someone's IQ was earlier in their life, and we would compare their score to that score. Sometimes we can approximate it, like if we know that someone was a physician, but at 75, their IQ is below average, we would expect that that represents a change because most physicians have average to above average IQs. So another application of intellectual testing is in autism. Many people with autism have domains of intellectual functioning where they're very superior to their other domains. So when someone has an IQ profile that's uneven, where they have relative strengths in some areas and relative deficits in other areas, sometimes that's an indication of autism or developmental disability. Lastly, though, intellectual testing is also sometimes used to identify intellectual giftedness. That's most often done in school settings, and that's one of the key jobs of school psychologists, to perform intellectual and achievement testing in schools. So achievement testing, whereas IQ testing is supposed to be kind of agnostic to how educated someone is, achievement testing is a direct test of how much someone has learned in formal schooling. It starts, I think the youngest age ranges that exist on this particular test, which is made by the same people who make the most common IQ tests, it can go as young as 3 or 4. And then the education attainment goes up to grade 12. So we would expect all adults above high school age who graduated from high school to have at least 12th grade proficiency on all of these domains. It's designed to identify academic strengths and weaknesses. And clinically, it's most often used to diagnose learning disabilities, which are defined as a significant difference between someone's intellectual capabilities and their academic performance. Learning disabilities are also usually domain specific. So people typically have a specific disability when it comes to reading, writing, or math, although some people have more than one separate learning disability. The premise of IQ testing and achievement testing is that in someone without intellectual disabilities or academic learning disabilities and who's had access to a full through high school education, their IQ and their academic achievement should roughly be in the same percentile. And when they're not, that's an indication of a learning disability. So some self-report questionnaires are more standardized than others. I showed you a couple different examples. Of the 3 examples I showed you, the Beck Depression Inventory is probably the most standardized in the general population compared to the Eating Disorder Examination Questionnaire, and definitely compared to the 9-item ARFID screen because that's a newer measure. But some questionnaires have been tested and normed in large populations, and these questionnaires are sometimes used in the context of other psychological testing to identify potentially clinically significant elevations on psychological symptoms. So this is a summary of the subscales from the Minnesota Multiphasic Personality Inventory, the MMPI, which is one of the most commonly used norm-referenced clinical assessments. We would never make a diagnosis just based on someone's scores on this subtest or any scale, any self-report inventory. It would always be followed up with diagnostic interviewing, so clinical interviewing, semi-structured interviewing, sometimes standardized testing. But norm-referenced questionnaires can be a way to help to flag problems that an individual might not spontaneously report. Because of that, questionnaires like the MMPI are often used in forensic settings or in legal settings where someone, for example, might be trying to get disability benefits based on a psychiatric disorder. The Minnesota Multiphasic Personality Inventory in particular has subscales that are designed to identify people who are lying about their symptoms. So malingering, which is pretending to have symptoms that you don't have, or people who are trying to hide their symptoms, which is also called faking good. On norm-referenced questionnaires, scores are standardized. So the score units are units of standard deviations, and the mean on a standardized score should be 0 for the population. 0 as in the mean doesn't deviate at all from the mean. Any individual score will be either positive or negative around 0. And a score, for example, greater than 1.5 might mean that someone is 1.5 standard deviations above the population mean. A score less than negative 1.5 means that they're greater than 1.5 standard deviations below the population mean. So for someone to get a normal score on this measure, their standardized score would be close to 0, meaning that they scored close to the population mean. So the end result of diagnostic interviewing and assessment, especially when that assessment involves psychological assessment, standardized testing, looks kind of like this. This is an example of a template that I used to use to write psychological reports when I was in grad school. So what this is showing, this is a psychological report for a 5-year-old patient. The presenting concern was related to autism and ADHD. So what these are different standardized tests that were performed in this case, an IQ test, an achievement test, a test of phonological processing, which is a test of someone's early reading skills, and the test of visual motor integration, which is a test of early writing skills. This patient also had normed and non-normed self-report questionnaires assessed, which in this case, because he was 5, were all filled out by parents and teachers. So the BASC, the Behavior Assessment System for Children, is population normed. So a normal score on this is 0. The ADHD rating scale is a symptom checklist. So there's not necessarily a normal score, but the higher your score on this measure, the more symptoms of ADHD are being endorsed. So those are kind of the two different examples of psychological questionnaires, norm referenced and non-normed. And then lastly, I did structured diagnostic interviewing using the Schedule for Affective Disorders and Schizophrenia for school-age children, which is known as the KSADS. So when someone undergoes a diagnostic assessment, it's their right to receive a full qualified interpretation. And that interpretation should be given in the form of a written report like this, written by or signed off on by a trained licensed psychologist or psychiatrist. So anytime you undergo a test of intellectual functioning or any of these standardized normed tests, you have a right to the answers, and you have a right to have the answers explained to you. There's another kind of testing that I didn't talk about because it's not as commonly used and you would never use it in children, but based in psychoanalysis and psychodynamic principles, the idea behind projective testing is that if you show people vague or ambiguous stimuli, they will project their unconscious thoughts, feelings, and desires onto those images without realizing that that's what they're doing. So there's really no evidence that this approach, this idea that people are reacting to these images in ways that reveal their unconscious, that's not known to be valid. It doesn't really help us make clinical diagnoses. And it's also not reliable. It's really hard to train people to interpret someone's unconscious projection in a consistent way. So we don't use projective testing like this for making clinical diagnoses anymore, although some practitioners do when they're planning to use a psychoanalytic approach. But that would just be used more as a clinical tool to learn more about the patient as an individual. It wouldn't necessarily be used to make a diagnosis. But this is an example. This isn't an actual Rorschach image, but this is like the 10 images from the Rorschach test. The Rorschach test is probably the most famous projective psychological test, and it includes a set of 10 ambiguous ink blots, and people are asked to just look at the ink blots and give different interpretations of what they look like or what they could be. So there is a modern standardized scoring system for this. It is based on the idea that it's a projective test, but nowadays it's more used to understand whether someone is processing stimuli and information in a normal way. So it's kind of used as a test of deviance, and it's often used to help diagnose psychosis, like sort of subclinical, subtle signs of psychosis. So probably like the stereotype around Rorschach tests is that if you see like a penis, it means that you're very psychologically damaged. That's kind of how popular culture has portrayed it. But actually there are some images, many images, where seeing a penis would be considered an ordinary response. Ordinary means that in the standardization normative sample, people gave that response. Other people saw it that way too. So this isn't a real card, but I would guess that an ordinary response would be seeing this central image right here as something like a teddy bear, or maybe someone holding up 2 flags. A normative response would be seeing this image as maybe like a crown, or maybe 2 shrimp holding hands. Again, those sound like weird, crazy answers, but it's just a perceptual reality that our brains are really good at making sense of ambiguous perceptual stimuli. It had survival benefits. When we were out hunting and gathering, our brains had to be able to make sense of sort of choppy, broken up, imperfect visual information quickly so that we could make decisions about that information. So we're used to, it's normal to see shapes and interpret things in like shadows, or to see a face on a piece of toast. That's all normal. A response to a Rorschach test that would be considered abnormal, deviant, and maybe indicative of something like psychosis would be a disorganized response, where someone gives an interpretation that makes no sense, where someone looks at this picture and says, this looks like the concept of war, or this looks like my left elbow. And when you ask them, okay, so show me in the picture where you see your left elbow, they either can't do it, or they show you something that doesn't look anything like an elbow to you. So even though it's standardized, when it comes to identifying disorganized or unusual responses, the clinician's judgment and personal experience has to come into play. An unusual response would be something that didn't come up in the normative sample, but that when you look at it, you can see it too, and the patient can explain it to you in a way that incorporates the outlines of shapes and shows that they're viewing these shapes as consistent wholes, that their interpretation of the shapes is guided by what parts of it are close together, what parts of it are touching. Someone who said, this looks like my elbow because this part is pointy and this part up here is long, that's a disorganized response because their brain isn't processing visual information in the way that most people's brains do. Most people's brains would process shapes that appear close together as wholes and would be more likely to see this part as separate from this part. Okay, so that's kind of the end of the assessment part of this lecture. We'll talk about diagnosis in class, but these are sort of the takeaways. These are the questions about assessment that I hope you can answer as a result of watching this lecture. So what's the goal of psychological assessment? What are the main components of a psychological assessment? Very importantly, what are reliability, validity, and standardization, and why are they important? And then in class, we're going to talk about, first of all, the difference between assessment and diagnosis, but then also we'll sort of engage with and debate about some of the concerns with the concept of diagnosis. All right, I will see you guys in class.